Hello and welcome. My name is Professor David Armstrong. I'm a doctor. I'm an NHS consultant. I work mainly in osteoporosis and rare bone disease. I also have a visiting chair at the Ulster University where I work with the Nutrition Innovation Centre for Food and Health, again mainly doing work on bone disease and nutrition. However, I'm not the star of the show today. That accolade falls to my colleague here, Dr. Sandra Iuliano from the University of Melbourne. Welcome, Sandra.
Thank you, David.
Are you enjoying the grey skies and steady cold rain of Northern Europe?
No, we've actually had good weather, so thank you. I must have brought it with me.
Sandra is a senior research fellow at the University of Melbourne in Australia. She has an international reputation in musculoskeletal research across really the whole lifespan, children, adults, athletes. Some interesting work in people who spend a long time in the dark in Antarctica and the effect that has on their bones. But really today we're particularly interested in the work you've done in older people and in people who live in care homes or nursing homes, as we might say. You published a remarkable study in the British Medical Journal looking at the effects of calcium and protein in dairy produce on falls and fractures in people living in nursing homes. How would you explain to our audience, just in a few minutes, the type of people were involved in the study, the intervention you did in the study, and maybe some of the findings or the main findings you got from the study?
Our study was done in 60 aged care homes in Melbourne, Australia. Half of the care homes were provided dairy so that they could actually give that to the residents, and the other 30 care homes went about just their normal menus, and this happened for 2 years. And we followed all of the residents for the 2 years. We monitored falls, fractures and mortality in all of the residents. So the residents in the intervention facility were consuming about 2 servings of dairy a day. That's Australian, so that's equivalent to perhaps around 3 servings by European standards. And we increased that to 3.5 servings per day. And that was maintained for the entire 2 years. The reason we chose this group of people is we know their high rates of malnutrition, low calcium intakes at around 600 milligrams, low protein intake around 0.8 grams per kilogram body weight, high rates of malnutrition, high rates of falls, high rates of fractures. So it's a group that's at really high risk. And following the 2-year intervention, we observed an 11% reduction in falls, a 33% reduction in fractures, and a 46% reduction in hip fractures.
Mm-hmm. And those are impressive figures. Certainly, if you're someone who hasn't looked a lot at nutrition research, to choose fractures as an outcome in nutritional intervention research, that's quite a brave thing to do. To show a reduction in hip fractures and a reduction of almost 50% in hip fractures, that's a remarkable outcome. And actually to do that over 2 years, it really does make this a landmark study. And I may use the term landmark a number of times here. I suppose that my first response to this, thinking as a doctor, thinking as a scientist, how do you explain these findings? Is it the group you were looking at? Is it the effect of the dairy produce? Where does this come from?
Look, there's 2 factors associated with that. One is that we've got a group of older adults that are very high risk, and also that they're deficient. So they had low calcium intakes, low protein intakes. So the benefits are likely to occur in those that have low intakes. One thing we did observe with our trial is that all but one of the fractures occurred from a fall. So by stopping the falls, we were able to reduce the number of fractures. To give it perspective, we observed 23,000 falls over the course of the 2 years. So while 11% reduction may seem small, when you look at the total number of falls, we prevented a lot of falls simply by improving their nutrition with just good old-fashioned milk, yogurt and cheese.
It's one of those things, again, as a doctor working in the clinic, sometimes you look at scientific research and you see statistical significance, but when you look at the actual difference between the groups, I know in the clinic it makes almost no difference. a 46% reduction, that's a real clinically significant effect. And even, as you say, the 11% reduction in falls, if that's reducing falls which are there in the sort of 20,000s you were saying, that does make a big difference. And we're increasingly aware, of course, not just of osteoporosis and osteopenia, but sarcopenia as well, and the huge connection between muscle strength and bone strength and how those organs communicate with each other. So is it applicable to the community dwelling people as well? So presumably if you live in your own home but you have a very poor dairy intake, poor protein intake, this might well be as useful for you.
Yeah, I think if someone is deficient and living in home, in a sense, those that are living at home we know less about, because we often don't know if someone's got inadequate calcium and inadequate protein until they present to hospital with an issue. So I think it would work in people as long as the same level of calcium inadequacy, protein inadequacy, and a similar type of person. There's no reason why it shouldn't work, because part of our trial we looked at the mechanistic aspects of it. And what we observed is that appendicular lean mass, so lean mass of the arms and legs, was maintained with the intervention but declined in the controls. We also saw that the volumetric bone mineral density, and we used peripheral sites, so at the radius and the tibia, was again maintained with the intervention, and we saw the normal age-related loss that we would expect in the controls. So we saw these differences, but we also have the potential mechanisms that may have brought those, results about. So it was about slowing the decline. The amounts that we provided, so the 3.5 servings by Australian standards, was enough to maintain. So I look at a lot of the decline is it's not necessarily age related. If we could slow the bone loss, we slowed the muscle loss, we slowed the decline into malnutrition, we slowed the risk of falls and fractures, what we've done is we've just slowed the decline that occurred at a rate that we saw in the controls.
And I suppose, does it have to be dairy produce? So could you have given these patients lots of calcium tablets, lots of phosphate tablets, lots of vitamin D, lots of whey protein, lots of casein, lots of magnesium, lots of all the other things that, could you have done that? Or does it have to be dairy, do you think?
We wanted to go with just a plain food-based approach. There's a couple of reasons for that. One is that the average number of medications is 12, and to then put in tablets for the protein, tablets for the, for the calcium, the numbers are huge.
I forgot to mention all the other tablets. You would need the fat and the galactose and all the other things.
So it would be just overwhelming for these people. And also we know that there is, there's a matrix effect with this food that we actually don't really understand properly. And so the benefits may be greater than the individual nutrients themselves. We just simply had vitamin D replete, older adults, and then we could just provide the additional dairy food. What we did do, it was milk, yogurt and cheese in any combination. So we worked with the food service staff and the residents. If residents preferred cheese, then more cheese was offered. If residents wanted more milkshakes at morning tea, then we offered more milkshakes. So it was very tailored to the actual individual facility, the care home, to the actual residents.
It was resident driven. If they wanted, so if they had a sweet tooth, let's say, they could have gone for more fruit yogurt, or if they had is there such a thing as a savoury tooth? I don't know, but if they preferred savoury, they could have gone for more cheese and so on. So it was very much resident driven.
Yes, what was offered is resident driven, and it was about provision. It was about having all those options available so residents could at least have the option of consuming it or not. And that was the good thing about it, what you just mentioned. If they're a sweet tooth, we had options that were sweet. If they're a savoury person, then we could incorporate it into savoury dishes. So it was across meals, it was across snacks, throughout the entire day.
And did you get any feel for the type of dairy produce that the residents did choose? Was that different in different groups? Was there any more beneficial, or was it not possible to sort of drill into that?
It was very individualised. So we also fortified with skim milk powder. So it was the methods were, there were probably thousands of different ways that we did it. Yeah. all depended on what residents liked and also how the chefs like to cook. That's a very important part of it, that if a chef likes to cook with certain ingredients and in a certain way, we didn't try to change that. We simply said, how can we accommodate your way of cooking and your ingredients?
Did you get any resistance from the kitchen, from chefs, from relatives, or did you find this was easy to put into homes?
Like with any group of people, you're going to get some that are really good, you'll get some that are more resistant. You can imagine within a facility, we would have morning chefs, evening chefs, we would have weekend chefs, we would have
I don't know how this works, so you're educating me now.
So what I'm getting at is per facility,
yeah. Okay.
you may be having to educate 5, 10 different people. Some are, as I said, some were really innovative and they would start to come up with ideas and they would create recipes and try them out. You'd have others that would do the bare minimum just because
they were told they had to do.
But also perhaps that they couldn't see the value in it. And I think the value is then in the results. They may perceive that it's just food on a plate versus actually now seeing, hang on, we can make a difference with what type of food we put on the plate.
Yeah, food is medicine and they can make a difference to people. I have literally come from a clinic just a few hours ago seeing patients with osteoporosis. Most of those patients, however, I was prescribing drugs for, and some of those drugs are expensive. Now the drugs work, they work very well at reducing fracture risk, but the price runs into maybe thousands of pounds a year. I'm guessing this probably had a better financial profile. What was your sort of cost base here to achieve these sort of results, 46% reduction in hip fractures? How much did that cost?
Yeah, so the mean cost was about £0.6 per person.
60 pence, let's say.
60 pence, thank
Okay,
you.
yeah.
60 pence per person per day. Right. So it wasn't an expensive intervention. But one of the key things we need to remember is that when we're prescribing, you are prescribing, osteoporosis medication, that person has demonstrated osteoporosis or a risk factor. Whereas we are feeding people, some of whom have osteoporosis, some of who don't. So we needed to do it in a way that is safe for all of them. So we needed, this intervention had to be something that we gave to all the residents, irrespective of their bone density, irrespective of their risk profile for osteoporosis.
It's safe and funny, when I was saying earlier there, just thinking if we prescribed all those different supplements and things individually, someone would probably come along and say, well, you need to check blood tests to make sure that the calcium's not going too high or the phosphate's going. You need to do all that. So because this was food-based, it wasn't presumably entirely natural and sort of safe in that sense.
Yeah, from our data, we had no difference in mortality between the two groups. We were asked that very question. If you give them all this additional dairy food, will it increase their cardiovascular risk? Which we knew we would be asked, but we actually did that and we saw no difference in mortality between the two groups.
Yeah, I mean, that was the question literally I was asked by a patient this morning, and people do sort of worry about that. So yeah, I think that's one of the probably reassuring things that came out of the trial. You did get some help from dairy organisations to fund this research, is that right?
Yeah, we did. We had funding from 7 different dairy organisations and research foundations from around the world, but we also had 3 non-dairy funding sources, the University of Melbourne, the Austin Hospital. But one of the key things is for the scientific integrity that none of the funders have any say in how the project is designed, how it's executed, how the results are analysed, and also where it's published.
So you had complete control over that?
Absolutely. It's an independent university-based project.
There are people who choose a plant-based diet, for example, and who may look at this and say, could you have given one group lots and lots and lots of vegetables to get their protein, and could you have supplemented them with other things? Did you not include an arm for maybe vegetarians? What do you sort of how would you answer that you didn't look at a plant-based option here?
Yeah, look, there's a couple of factors. One is if we had another arm, so if we had a plant protein-based arm, we would then have to have 90 facilities, so someone's going to have to find that extra money. The other thing we need to remember is with older adults, especially those in care homes, they don't have big appetites. So we know from our data, we had about 1.6 kilograms on average. That's how much food they consume. Right. So I can't provide them with necessarily with plant-based sources, because if I need to provide them with 3 kilograms of plant-based sources in order to get the same amount of calcium and protein, they physically can't eat it. So young, healthy people may be able to, but for our older adults, I think we really need to consider what they can consume. What we're after is high nutrient content. So we can't spread it across a large amount of foods.
Why do you think this is so important, or what would you like people sort of their take-home message to be from the work that you've published?
Yeah, I think, look, there's a few things. One is that we're demonstrating if you actually provide that amount of dairy food and foods that they know, that it actually has good clinical outcomes. So it's in the best interest of both the residents and providers to have that, because we're going to be reducing their clinical costs because there's lower negative clinical outcomes. It demonstrates that food can be medicine, as you mentioned earlier.
Hippocrates, food is medicine. Yeah.
Yeah, and the final thing is that, you know, we have an association between dairy and bone. We've known it, but we've never had the evidence to show it has anti-fracture efficacy. And this is now the evidence that we needed. So therefore, you know, you can look at things like dietary guidelines, you can look at things like policy, you can look at things like, you know, consumers and what consumers are eating, and we actually know it has a clinical benefit.
So you must have policymakers like beating a path to your door now, you know, wanting to get you on board, asking what they can do. Is that right? Or you find you're struggling still to get yourself heard? Or maybe that's the next step, is it?
A lot of it is. So I think there's 3 levels that we need to work at. There's the level at the policy level, so that we can ensure that policies, you know, both nationally and at, you know, a care home based level, support good nutrition, and this is part of their good nutrition. I think at the care home level, we can look at education and policy so that the staff are equally aware of the benefits of, you know, nutritious food. And on the individual level, you know, we need to think, you know, often the clinicians may not consider food in their application, and now we can show that their clinical judgments and their clinical treatments can be enhanced by food.
Look, it's been fascinating talking to you. I described this as landmark research, and I set myself a number of times I would use the term landmark during the interview, and I think we've exceeded that. I really do hope people are talking about this in 30 years. I think it's big implications for patients, for medical staff, for policymakers. It's very exciting to hear all this being discussed. That's great. Sandra, thank you very much indeed.
You're welcome, David.